Hi and welcome to another episode of Coding Matters, and on this occasion we have a great focus on rehabilitation, and I'm delighted to be joined by Dr. Maria Paul. Maria, what's your background and what do you do as a job at the moment?
I'm a medical lead in rehabilitation for CALHN, and I work in brain injury rehabilitation service but also oversee all the rehabilitation services in CALHN.
Okay, well thanks for lending your expertise to this episode. One of the things that differentiates rehabilitation, along with a couple of other areas, from a lot of the other inpatient coding, is the fact that we use a different system. So if you've seen some of our other videos in Coding Matters, you would be somewhat familiar with the DRG activity-based funding model. That's the diagnosis-related group, which allows a certain amount of coding to come within a specific framework of DRG from the clinical documentation. However, in rehabilitation, ideally we would like to use a different group that's called ANSNAP that is more tailored to rehabilitation. Tell us a bit about ANSNAP and how it differs from DRG.
Yeah, ANSNAP stands for Australian National Subacute and Non-Acute Patient Case Mix, and it's a much more specific case mix adjusted group. In order to get to an ANSNAP category, you need to document certain things, and on Sunrise, our electronic medical records, we have something called AROC version 4 document. And once that documentation is complete, which includes things like patient's age, when they were rehab ready, when they were assessed, what is their admission film, discharge film, etc., then we have all the information required to put them into an ANSNAP category.
And what's the benefit of ANSNAP over DRG from your perspective?
Because it's much more specific and it reflects the complexity of the patient, the funding that we can attract is a lot more commensurate with the complexity that we are treating. And we can give some case examples to illustrate the difference between somebody who had incomplete AROC data and therefore went into the default DRG funding versus when the AROC data was complete and they got the full ANSNAP funding.
So it's really more tailored to your particular nature of practice. And therefore the funding is more reflective of the management that you're providing for your patients.
That's correct, yeah.
And I suppose although it requires perhaps a little bit more detail in the data collection and documentation, that data can also be helpful for rehab data purposes as well.
That's right.
Okay, so we'll just look briefly through the essential ingredients for coding ANSNAP. The initial data is very similar, and so the same principles apply in terms of being very specific and being relational in your documentation with specific issues, and if there are past history or comorbidities that are influencing current management, they need to be documented clearly in the relationship established. And then there is a specific AROC impairment code, and so that's where things start differing from DRG.
That's correct. So in the AROC document, one of the first things we'd be entering is the AROC impairment code. So for example, somebody comes in with a traumatic brain injury. The impairment code might be either 2.22 or 2.21 based on whether it's a closed injury or an open injury. And then subsequently, we record other things like the functional independence measure scores in motor and cognitive that will further help to classify correctly.
Okay. And then there's some other, there's age, and then there's FIM. I notice there's FIM motor and cognitive scores. What's FIM?
FIM stands for Functional Independence Measure, and this is one of the biggest outcome measures we use in rehabilitation. So somebody might come in at the start of rehab, and with the lowest FIM score they could get is 18 and the highest 126. And our aim in rehab is to try and get them as high as possible before discharge.
Okay, so that's a really helpful clinical tool as well as for ANSNAP data.
Correct.
Yeah, okay. So if we contrast a little bit more about AROC versus DRG, in DRG we usually have a principal diagnosis that informs which code of DRG it goes under, and a similar thing occurs in rehabilitation in that because we're doing ANSNAP we have an AROC assignment that is similar to that principal diagnosis. And much like the DRGs, the which code it sits into and the severity and complexity is informed by detail. I suppose one of the key differences is that we often have a specific AROC document that we fill out, which is really important for data collection. But to be coded appropriately, we still need to rely on that really high quality documentation where we provide appropriate details to flesh out that principal diagnosis and reason for rehab. You had an example about brain injury. Do you want to contrast some different brain injuries?
Yeah, so for example, if somebody has a traumatic brain injury, on the AROC document, we'll be putting the impairment code as either 2.21 or 2.22 based on whether it's a closed or open brain injury. However, that's just on the AROC document. This has to be supplemented with proper medical records, either in the admission notes or ward round notes, clearly describing what the impairment is. So it's a closed brain injury. So that needs to be clearly documented, because coders can't just look at numbers like 2.11, 2.22 and make sense of what it is.
So I suppose using some of the examples that we've got listed here, if we were just to write CVA or stroke, that's not cutting the mustard in terms of quality documentation, and it's not going to help for AROC. We need to be very specific in saying this was for example, an ischemic stroke due to atrial fibrillation with ongoing deficits of left-sided hemiparesis and dysphagia. So linking those, the initial injury, so it's appropriately defined, and the ongoing impairments that we're really targeting from a rehabilitation perspective.
Yeah, that's correct. It has to be as descriptive as possible.
So the same ideas that we've talked through in those same themes of quality documentation and putting relationships between the detailed injury or diagnosis with supportive findings, along with, particularly in rehab, the nature of the deficits and the nature of the management that are addressing those deficits is really important. So we'll come back a bit more to talking about ANSNAP versus DRG, and we've got some really good examples that contrast the difference in funding based on the same really care and injury with appropriate documentation. But if the AROC is incomplete, we don't meet the criteria to access that ANSNAP funding. So we can see in this first example, we've got an 82-year-old patient who was brought by ambulance to ED with a traumatic hip fracture, a pretty common reason to come in the older age group. They're admitted and had surgery with a hip replacement, and once they're stable, they are transferred to rehabilitation. This would be a reasonably common reason to transfer to your service. So if this was not completely documented and the appropriate AROC data was not collected, we're really going to end up with about $5,000, a bit over $5,000 in terms of remuneration for that admission, which is probably not really reflective of the nature of investment that our services have made into this person's recovery. However, exactly the same situation with the appropriate data provided is going to access a little bit over $16,000 for that person, which is obviously much more reflective of the amount of time and energy, expertise and equipment that's gone into this person's recovery to give them the best chance of returning to good functional life.
That's correct.
Why don't you talk us through this second example?
So here we have a 43-year-old patient following motorbike accident. He has suffered fracture dislocation of his cervical vertebra, but also spinal cord injury at the same level. So if the AROC data is incomplete, we might get a funding of close to $7,000. However, if the AROC data is complete, we are going to get something close to $56,000. This is a huge difference, and the $56,000 is more commensurate with the amount of resources we have put in to treat this patient and rehabilitate this patient. So it would be very unfortunate for us to lose out on funding for the amount of work that we are putting in and on the care that we are providing for the patient. So it just highlights the importance of complete documentation.
I mean, that factor of almost 8 times the difference in funding, I think we've rarely seen such powerful examples, even in the other specialties, to see the difference between that. And I suppose for your services long term, that's the difference between a skeleton-based service versus a service that is really well-staffed and well-equipped to provide really high-quality care for our patients.
That's right.
Here's another example, a young person, 24, who was also brought to ED with a hypoxic ischemic encephalopathy, admitted to ICU and spent some time being intubated and ventilated. And once they were medically stable, they were transferred for rehabilitation care. So in this instance, a lot of the rehab is focused around a brain injury from the hypoxic period, and most likely some critical care, myopathy, deconditioning type things as well.
Correct.
If we only rely on DRG-based funding because we haven't provided appropriate data for AROC, we can only access $15,000, about $16,000. But here we can see a huge increase if we were to appropriately document and capture that AROC data ANSNAP will provide closer to $82,000. Again, a very powerful example showing the difference between these two funding models.
So here we have a 69-year-old patient admitted for cardiac rehab following bypass surgery. And again, if we go on to DRG funding, we get around $3,000. And with complete AROC documentation and ANSNAP category, we get close to $14,000. Again, huge difference.
Absolutely, quite powerful examples. Here in CALHN, we're currently undergoing quite a large audit of our rehabilitation data and comparing where there are areas of insufficient AROC data capture, and therefore we haven't accessed the ANSNAP data. So we're still partway through this, but we've seen almost 760 admissions reviewed, and almost 100 of them were unable to access the full ANSNAP data and therefore funding. And so even if you take about half of them at 50, where we've gone back in and entered the appropriate data and corrected the funding to be ANSNAP funded, that's resulted in a lift in funding of almost $750,000. Like, that's a huge amount of money for even just 1 year or even part of a year, and we're expected to see that will rise as we complete the audit with the remaining records to probably well over $1 million in difference in funding. I mean, to you as a manager and executive, that's a very significant area that we should be focusing on.
That's right, and this is being paid for work we are doing.
Absolutely.
It's not asking for anything more.
Yep.
So it's just that not losing out on funding because we are not documenting things properly. And documentation isn't hard. The AROC document is one simple document on Sunrise, and my biggest advice would be to fill that contemporaneously. So as the patient comes in and starts their rehab, within the first week you'll have a case conference, start filling in that document so that it's complete by the time the patient is discharged. It's very difficult to retrospectively come and correct the errors, months or weeks later. So that would be my biggest piece of advice to our clinicians.
It's a reasonably thorough data set, but it's not hard to get that data if the person's in front of you and you're actively managing them. So within Central Adelaide Local Health Network, and now across many of the local health networks in South Australia, we're all using the same electronic medical system, Sunrise, by Allscripts. And we just included a de-identified example of part of the AROC data collection tool that we use. So if you're working or about to work in rehab, this is what you'll be using on a regular basis, and we'd encourage you to be familiar with it. If you're from interstate, you may have a similar tool, or perhaps if you're still working on paper, hopefully you have a template on paper that's available to you to be able to capture that same data. Any tips particularly on the AROC data collection, apart from doing it timely-wise?
Timely. The other biggest tip I can give is that whatever you document on AROC, there has to be a concomitant medical record documentation that explains the message behind your numbers and all of that. Because a number like 2.22 or 2.21 may not make much sense to the coders, but if you write it's a closed brain injury or open brain injury, that can be coded correctly. So it's really important to maintain good medical records, and especially the plan during ward round notes or any of the contemporaneous notes, the plan, what are you doing, what treatment are you providing, and what for, that needs to be clearly documented.
So really the data that we're including and coding into the AROC is ideally all reflected and fleshed out more in the actual clinical record, whether it be a ward round note or medical progress notes or partly their admission and discharge documentation.
Absolutely right.
So we'd like to move on a bit from ANSNAP. That's one of our major takeaway messages for this video because it's such a powerful example of tailored data collection and tailored funding for a specialty area. And we'd like to talk about really a framework for documenting rehabilitation admissions. One of the big differences here is that, as with many specialties, people come with a particular specific range of reasons for admission into a rehabilitation service and management that fits those reasons as well. So being really clear about what was the nature of the injury or medical condition that led to the need for rehab, and what are the ongoing deficits at the point that they're transferred or the point that they're referred that are going to be the focus of rehab. And it's sometimes can be oversimplified, but actually most of your patients have multiple deficits or multiple areas that need specialised focus. Is that fair to say?
Yes, that's correct. And as part of the documentation, if the patient comes with a particular reason for rehabilitation, whether it is rehabilitation following spinal cord injury or following stroke, if they have any comorbidities that might interfere with their rehabilitation progress, that needs to be spelled out quite clearly. So, for example, if they have increased risk of falls because they also have comorbidity of Parkinson's disease, that needs to be clearly documented.
And I suppose on the rare occasion that you take our haematology patients, they might occasionally require top-up transfusions, and the fact of the anemia being present may actually cause them to have less stamina and more fatigue, which would then influence their duration and the intensity of rehab they can manage.
That's right. Yeah.
So any kind of comorbidity, diabetes, anemia, other things, even Parkinson's we were talking about previously, anything that requires active management or indeed has a specific impact on the nature or pace or duration of rehab needs to be documented clearly, and that relationship of how it is impacting the current management clearly spelt out, and that will enable us to appropriately capture that complexity. So here's some specific examples we like in Coding Matters to talk about whether we're writing symptoms, signs, or just pieces of data versus writing diagnostic terms. And so it's okay to write those first things as long as you then actually put a clinical impression or some kind of diagnosis or assessment that is in keeping with that. So terms like functional decline, although you and I would deal with functional decline on a regular basis, that is not a medical diagnosis. That's just a kind of a non-clinical impression of sorts. But physical deconditioning or muscular deconditioning or myopathy, they are specific reasons that may contribute to that impression of functional decline. Again, confusion is a symptom or a sign. Delirium or cognitive impairment that is linked to dementia or neurocognitive disorder, they are the appropriate terminology that we're using. What are some of the examples that you might see sometimes and think we really need to be more specific with that within the rehab context?
I guess a common one is fatigue, and we have to just specify cognitive fatigue due to hypoxic brain injury or something really specific rather than just fatigue.
Okay, so that relationship between the injury that we're focusing on, the deficit that we're focusing on, and comorbidities that are influencing there as well. To summarise some of the areas we've talked about, we've had a big focus where we've contrasted diagnosis-related group activity-based funding, so DRG-based versus ANSTAT, which is tailored specifically for rehabilitation, and the AROC data that influences that both needs to be entered specifically into some kind of data capture form, but needs to be reflected in more comprehensive detail in our clinical records like the ward round note, discharge, admission, and other medical documentation. We've seen some quite powerful examples of the difference between DRG-based funding when we don't have appropriate AROC data to access ANSTAT funding, and we've also seen the big lift in funding that is more appropriately in reimbursing the management of the patients that we have in rehabilitation via the ANSTAT funding model. And we've also looked at the importance of high-quality documentation and a framework that clearly has relationships and detail around their initial injury, the nature of the deficits, and the relationships between comorbidities and management. Thanks very much for joining us, Maria.
You're welcome. Thank you.